Good day, I'm Dr. Ian Johnston. Today I'll be presenting the fourth in our series of lectures entitled ADHD, a Toolkit for Parents. Today I will be continuing my discussion of the comorbidities associated with ADHD. In the first lecture, I discussed the academic and behavioral diagnoses that we often see with our patients in the office. Today I will be moving on to the more classically medical diagnoses, including depression, anxiety, obsessive-compulsive disorder, bipolar disorder, and tic disorders. Let's start with depression. Although everyone complains of being depressed from time to time, being in a bad mood is very different from carrying the diagnosis of major depression. Depression is clearly a medical condition. It's very genetic. It runs in families. I think of it as much as a disease as I do diabetes and other common conditions. Although there's a tendency to think that young people do not get depressed, in fact we see it very frequently in the office. We see it occasionally in the younger children, but see it quite often in the teenage population in particular. Teens tend to present somewhat differently than adults. While adults tend to get slow and sad when they get depressed, the teens look a little bit different. They often present as academic problems, behavior problems, and very frequently as substance abuse problems. It's important to think of depression whenever one sees a sudden decline in functioning, either in an ADHD child or in any teenager. Depression has clearly defined diagnostic criteria, which I've listed out in the following slide. As we can see, depressed mood, of course, is part of it. I find the biggest flag in the teenagers is when they stop wanting to take part in pleasurable activities. Teenagers in general are always wanting to get out and do things. When the teen stops wanting to do this, is spending more time at home, especially if it's sitting alone in their room or listening to music, this is very often a red flag. We see a loss or gain in weight, an increase or decrease in sleep. The children rarely get slowed down to the extent that the adults do, but this is described at times. They often feel tired, they feel guilty. One of the problems is they also describe a decrease in focus. When I'm referred someone with ADHD at a relatively late age, one of the first things I think about is depression, because ADHD is not something that presents in the teenage years without signs of the condition earlier on. Similarly, when we have an ADHD child who's previously been very well controlled but suddenly seems to be backtracking substantially, depression is something we have to think about. Many of the children will also describe thoughts of death, although you have to ask very specifically about this to elicit it. Although not part of the diagnostic criteria, we frequently see substance use in the depressed teenagers. Really what they're doing is self-treating. Marijuana is the typical example. The child who is depressed or anxious will often turn to this substance in an effort to feel better. Similarly, in the teenage girls we see a lot of skin cutting. Although it's counterintuitive, this in fact is a method that they use in an attempt to make themselves feel better. The following slide describes some of these red flags that we look for in the office. If it is recognized, depression is certainly a treatable condition, and we have some success treating it in the office. Treatment should always include attention to personal habits. Things like diet and sleep tend to go off the rails when the teens in particular get depressed, and it's important to really focus on these things. There's good evidence that regular exercise is quite effective in treating especially mild to moderate depression and anxiety as well, and this is something that needs to be emphasized. Very often we also suggest talking therapy. Ideally this includes cognitive behavioral therapy, but any type of counseling is helpful. In some cases, and not in rare cases, we do end up using antidepressants. Antidepressants in teens and younger children is certainly an area of some controversy. They are useful medications, although they have to be used with some caution. When I compare my patients on antidepressants to my patients on stimulants, quite frankly, I find the antidepressants to be much kinder and gentler medications. For the vast majority of patients, the side effects are much milder. One has to be aware, however, that when one starts any patient on an antidepressant, particularly a depressed patient, about 3%, so 1 in 30 of those patients, will develop increasing dark thoughts and thoughts of death. Of course, we expect the opposite, but this subset of patients, 1 out of 30, seem to go the wrong way. And one has to speak very specifically to both the patient and the family about this. A slightly larger proportion of patients will become a bit hyper when they're placed on an antidepressant. I always wonder whether these are bipolar individuals who are being unmasked. But again, this is something that has to be discussed specifically with the family and with the patients. For the majority of patients, however, the side effects are quite mild. The main problem with antidepressants is that they're very slow. We really don't get much of a response until about the 4-week mark, and we don't get a full response until the 8-week mark. Teens by nature are impatient, and it's important to emphasize that these medications take time. Moving on to anxiety, this is probably the most frequent medical comorbidity that we see in the office. Certainly not as common as learning problems, but extremely common nonetheless. We see them not just in the teenage group, but we see them fairly frequently in the younger children as well. There's a tendency to question what young children have to worry about. Anxiety is definitely a medical condition, very much like depression. One doesn't need a good reason to be worried. It's just something that happens. It's very genetic and very chemical, just like depression. That being said, all anxiety is not pathological. We all have anxiety, and anxiety to some extent is a good thing and is a motivator. It's when it begins to impair function that a diagnosis can be made. The next slide looks at the various subtypes of anxiety. We have the generalized anxiety disorders, as well as children that just have difficulty in social situations. Separation anxiety is, of course, quite common in the younger children. We see lots of panic in children of all ages. Specific phobias are actually relatively uncommon in the younger group. Selective mutism are children who, under certain circumstances, refuse to speak at all. This is sometimes at school or sometimes any time outside of the home. Relatively uncommon, although we do see it from time to time in the office. To rate as pathological, the anxiety has to be excessive, it has to be pervasive, it has to occur most days. It's not easily controlled. It affects the children's functioning. That's the key issue. They feel restless, they have difficulty with concentration, they often are tense and have difficulty with sleeping. Many of our children are really unable to function. They're unable to get to school, they're unable to visit friends, they're unable to take part in many of the activities that one typically associates with a happy childhood. This is not just being a bit of a worrywart. The treatment of anxiety is in many ways similar to the treatment of depression. Chemically, they're very similar conditions. Again, talking therapy forms the cornerstone of treatment. There are a number of good resources to use at home that people have used with some success. If these approaches are unsuccessful, antidepressants can be used as well. Parents will often ask me, why are you giving my child an antidepressant? They're not depressed, they're just anxious. The treatment is the same, as these two are very closely linked conditions. And as we will see, the treatment of obsessive compulsive disorder can also involve the use of antidepressants. Moving now to obsessive compulsive disorders. In many ways, I consider it to be similar to anxiety, and at times it's difficult to sort out what is obsessiveness and what is anxiety. In fact, it doesn't matter a great deal in that the treatment is fairly similar. Obsessions are unwanted thoughts. It could be thoughts of being a bad person, thoughts of wanting to harm people. We see a number of different obsessions in the children. More common, however, are compulsions. These are recurrent unwanted behaviors. Very often they're washing. Sometimes they're counting, checking. A lot of the children will want to do things a certain number of times. Whenever they pass a certain table, they have to do something 4 times. And this can be quite disruptive if the number of compulsions are large. The treatment is similar to anxiety, talking therapy, as well as the use of pharmacological agents such as antidepressants. Now, let's move on to the diagnosis that I love to hate, bipolar disorder. This is a condition that comes up frequently in the office, but is actually a diagnosis that is made quite rarely, at least in my practice. The common misperception is that bipolar disorder is seen in someone with swingy moods, and quite clearly bipolar disorder is not just someone with violent mood swings. As we discussed earlier in the previous lecture, there's a whole condition, the explosive disorder, which describes these individuals. In fact, bipolar disorder is a fairly difficult diagnosis to make in the pediatric population. The main reason for this is that 90% of individuals with bipolar disorder will also meet criteria for ADHD, and ADHD is far, far more common. The most common subtype of bipolar disorder in the younger population is what's known as bipolar II disorder, which presents predominantly with depressive symptoms. The highs are relatively uncommon, which makes the diagnosis that much more difficult. The children also tend to cycle a little bit more rapidly than the adults do. The adults have highs that last a number of days and lows which can go on for good periods of time as well. The teens and younger children can switch several times within a day. That being said, it's not just an explosive change as we see in the childhood explosive disorders. Differentiating the highs of bipolar disorder can be extremely difficult to differentiate from ADHD. They're really quite similar. They're just a couple of things which differentiate them. ADHD children tend to have chronically low self-esteem, as the parents with the ADHD children will attest. Bipolar individuals have at least some periods of elevated self-esteem. That's the grandiosity that we see in the adults. Sleep for ADHD patients is difficult, but with the bipolar individuals, the sleep is an incredible problem. They can often just sleep a couple of hours a night and then be full of energy the next day, which is somewhat different than what we usually see in the ADHD individuals. We don't see the high levels of goal-directed activity in ADHD that we sometimes see in bipolar disorder. This could be very inappropriate goal-directed behavior, but it is goal-directed nonetheless. The other interesting thing we see is sexual acting out a little bit more frequently in the bipolar individuals. It's interesting that we don't see this frequently in the ADHD children. It's true that they do have trouble with increased frequency of unplanned pregnancies and such things, but inappropriate sexual activities, particularly in public, is not something that we see very frequently at all with the ADHD population. On the other hand, we do see it from time to time in the bipolar population. The treatment of bipolar disorder tends to be pharmacological. We use mood stabilizers such as valproic acid or lithium. I must say that the majority of the time that I entertain this diagnosis and go ahead with a mood stabilizer, I'm disappointed with the results. own feeling is that it's a relatively uncommon diagnosis in the younger group. This is certainly an area of controversy among psychiatrists and pediatricians. Moving on once again to something that we do see with some frequency in the office is tic disorders and its less common relative Tourette's syndrome. Tic disorders are quite common. They generally involve motor movements, very often involving the face. Probably the most common ones that we see are eye blinking, some grimacing, some mouthing movements. There's a number of common ones, and they can look like just about anything. We also see vocal tics. The most common vocal tics are guttural sounds in the back of the throat. We have the children who are constantly making a sound like as though they're clearing their throat. Although not classically a vocal tic, we see a lot of sniffing as well. The children will sniff frequently and will say that they have a runny nose or they have an itchy nose, when in fact it is a tic. Although we have all seen on TV people who say complete words as part of a tic disorder, this is actually quite rare. The coprolalia, saying bad words as part of a tic disorder, is something I've actually never seen in my practice in any event. Most of the patients that I see have simple tics. The tics can change over time, but they're usually not a large number at once. Tourette's syndrome, by definition, involves multiple motor and vocal tics which are present over time. So this is a much less common diagnosis than a simple tic disorder. When to treat a tic disorder is a very subjective thing. Tics are not at all dangerous, but they can be very disruptive and embarrassing for the individual involved. So generally speaking, I ask the patient themselves how much this is bothering them, and the responses you get are very variable. We have some patients coming in with fairly severe tics, but when asked if it's embarrassing or bothersome for them, they just shrug and say no. One asks if their friends make any fun of them, and they shrug their shoulders again and say, it's really not an issue. A case such as that, treatment really isn't necessary. On the other hand, we see some patients coming in with really quite mild tics, but who are very embarrassed and very self-conscious about them. And one's much more likely to treat that child than the more severe child who's not bothered by the condition. Unfortunately, treatment of tics is quite difficult. I find it to be very frustrating. There's a number of medications that we use, including clonidine, pimozide, risperidone, and quite frankly, none of them work very well. The natural history of tics is to get better and worse with time, and when I'm in a cynical mood, I sometimes wonder whether I just change medications until the tics get better on their own, and then congratulate myself on being successful with treatment. In any event, treatment is difficult and frustrating for this condition. Once again, non-medical therapy is possible. Again, it consists mainly of cognitive behavioral therapy. Unfortunately, accessing this can be quite difficult. There's a clinic in London that specializes in this. It's known as the Break Shop. Unfortunately, accessing this can be challenging at times. In summary, any of these conditions can be seen on their own. We see many children with depression or anxiety or obsessive compulsive disorder who have no sign of ADHD. That being said, the frequency of these conditions is significantly higher in children who have ADHD. For this reason, a complete assessment of any child or adolescent with ADHD must include a screen for these comorbidities. If these comorbidities are not addressed, the treatment plan is generally quite disappointing in its results. This concludes my discussion of the comorbidities associated with ADHD. I hope that you have found these talks to be helpful.